Yes, happy to. It's my pleasure to introduce Dr. Molly Wilson Murphy, who did her training at Hopkins, and then all of her residency and fellowship, including neuroimmunology and neuroinfectious disease at Boston Children's Hospital. She's interested in autoimmune diseases and infections of the central nervous system, and so delighted to have her talk about the initial evaluation for AFM. Take it away.
Thank you so much for that kind introduction, Grace, and to all of you for inviting me today. So I will be talking about the initial evaluation of AFM, including the essential exam. And so I will be reiterating a few of the points that Dr. Otten made, and the workup of AFM will be the main focus of my talk. We'll be going through key points of the physical exam, just reiterating what Dr. Otten went through, and some additional points on that. And then going through imaging recommendations, recommended labs, including LP, blood work, NP swabs, stool, etc. Okay, we can advance. We can just skip over the next slide. Yeah, you can go to the next one. Perfect. Okay, so importance of the physical exam and particular physical exam points to make. So as Dr. Otten reviewed acute flaccid myelitis, the diagnosis requires flaccid limb weakness, so low tone and or diminished or absent reflexes. So in that, the tone exam, the motor strength exam, and the reflexes are obviously all critical. But additional points of the exam that you want to focus on are the musculoskeletal exam to look for any limb deformities or signs of injury, which might suggest an alternate diagnosis. The mental status exam, so altered mental status with encephalopathy or seizures could suggest particular infectious causes of acute flaccid paralysis, such as West Nile or enterovirus A71, or could alternatively suggest autoimmune causes of encephalomyelitis. So the encephalo referring to the encephalopathy or the seizures, and the myelitis to the inflammation of the spinal cord, the myelitis. In that case, autoimmune causes, including ADEM, where MOG antibody, which we'll talk about a bit later, accounts for about 50% of cases. Cranial nerve exam. So again, reviewing that evaluation of the optic nerves is important in any case where you're thinking about myelitis, and you're evaluating for visual acuity, red desaturation, so things that are red appearing more gray or more orange, papilledema, and that optic neuritis is more likely to be seen in autoimmune causes of myelitis, where you have a myelitis and an optic neuritis together, which can be seen in conditions such as MOG antibody disease, neuromyelitis optica, or multiple sclerosis. And then other cranial nerve involvement, to reiterate that, that certain infections, particularly enterovirus A71, but also D68, in many cases are associated with cranial nerve involvement in addition to the myelitis. Lyme is also a consideration in Lyme endemic areas, and MOG antibody disease. The sensory exam, as Dr. Otten said, significant sensory involvement may suggest transverse myelitis as an alternate diagnosis rather than AFM, but pain and hypersensitivity and can often be seen in AFM and can be a significant proportion of the patient's complaints. Coordination and gait are important to assess, while arm weakness is more often involved than leg weakness. If there is leg weakness, you can have, gait difficulties, but if you have discoordination or ataxia, that would often suggest an alternate diagnosis. We can advance to the next slide. Thanks. So important considerations when evaluating a patient and doing your exam, again, would be their respiratory status and their bulbar symptoms. An evaluation for bulbar function and respiratory muscles is essential with all of these patients. Again, they can have difficulty swallowing or handling secretions and with breathing. And unlike when you're assessing a patient with respiratory distress and other conditions, they may have weakness of their accessory respiratory muscles as well. So you may not see that work of breathing that you would see in other conditions. And if a patient is able to cooperate, we recommend negative inspiratory force in all patients where you suspect AFM. And as Dr. Otten showed in her timeline, this can evolve over days. And so while it's important to assess a patient initially, if their respiratory status is okay initially, not to be sort of falsely reassured, because they can evolve to develop respiratory weakness and difficulty handling secretions as they go along. So very low threshold for ICU, either evaluation or level of care if needed. Next slide. Autonomic manifestations are fairly common. So they can have autonomic instability with blood pressure lability, temperature instability. So important to keep an eye on their vital signs. And they can have pain very often in their neck and their back and then their extremities, as Dr. Otten had also described. But the hyperesthesia and pain can be a significant complaint for many of these patients. Bladder and bowel function. So urinary and stool function are critical to evaluate. Many children with AFM are quite young to be able to tell you that they have inability to urinate or stool or to even detect it. They might be diapered, and so it's hard to assess how frequently they're urinating or stooling. And even older children with myelitis oftentimes don't recognize bowel and bladder symptoms. So it's important to have this very high on your radar and to do things like intermittent bladder scanning and monitoring for large post-void residuals, because it can be incomplete urinary retention, for example. And this, again, can evolve over time. So in terms of radiographic evaluation for these patients, we recommend MRI of the entire spine, CT and L spine, ideally with and without contrast. But if a patient is unable to tolerate a very prolonged scan, at least doing with contrast, if there are no contraindications to contrast, is quite important. The classic finding is the central gray matter involvement, T2 flare hyperintense signal, but it can also involve more than central gray and can involve white matter. Early on, you may only see anterior horn cell involvement, or you may see the MRI may be normal very early on in the course. While we talk about cord edema being more common in other conditions such as transverse myelitis, you can see cord edema with AFM. And so if you see significant cord edema, you may see more involvement than just the central gray, because it's more extensive with edema. You may or may not have contrast enhancement. And in other conditions where you have myelitis, for instance, multiple sclerosis, and you have a patient with known multiple sclerosis who has a presentation consistent with myelitis, you might just image the C and the T spine because you're looking at the cord. But with AFM, it's important to image the conus and also the cauda equina and the nerve roots, because you can have cauda equina and nerve root enhancement, which in some cases may be delayed, but if you see that, that can be another supportive factor leading you toward the diagnosis of AFM. And then if the imaging is initially normal and you have high suspicion for myelitis, if possible and resources are available, repeating the MRI, as you may have delayed radiographic findings. Additional imaging, in almost all cases, we recommend an MRI of the brain, particularly important if there's any altered mental status or cranial nerve or brainstem findings. However, because you can have asymptomatic brainstem or cranial nerve involvement, it's, if possible, it's important to image the brain as well. And then if there are any signs on exam of possible optic nerve involvement, doing an MRI of the orbits as well. Lumbar puncture is very important, particularly if there's no contrast enhancement on the spinal cord imaging to support your diagnosis that this is an inflammatory condition. But we recommend in all cases of suspected AFM doing a lumbar puncture and getting routine studies. So that's the cell count. And oftentimes you have a mild pleocytosis that can be a lymphocytic pleocytosis, though in some cases your cell count may be normal. In many cases you have a slightly elevated protein, but again can be normal. Glucose is typically normal. The Gram stain may show some cells, but should not show organisms. Organisms would be consistent with an alternate diagnosis. And then other studies to obtain on your CSF would be enterovirus PCR. Now, an enterovirus D68 AFM, the enterovirus PCR has been negative. There have been cases where enterovirus D68 has been found in the CNS, but not in AFM. But it's important to obtain it anyway, including if you're thinking about potentially other enteroviruses. Also CSF for enterovirus testing at the CDC, which I believe we'll hear more about later. And then other causes of acute flaccid paralysis. So West Nile virus serologies in the US. And you may consider other arboviruses, which can also be associated with myelitis, depending on the geographic location and the season. HSV 1 and 2 PCR, less common cause of myelitis, but important to rule out in terms of when thinking about your treatment. Clonal bands from the serum and the CSF, given that demyelinating presentations are a consideration, and then a CSF hold for thinking about additional studies. I oftentimes will get this initial workup and a hold, and then based on the rest of my workup, that will guide whether I obtain other studies such as CSF ACE, looking for sarcoid, neopterin, if my routine studies are normal, looking for evidence of inflammation. And then other infectious studies that I think about are things like VZV, EBV, and CMV PCRs. Serum studies in all patients with AFM, we typically will get a CBC with differential, a chemistry, particularly if they have bladder and bladder involvement, looking at their BAO and creatinine. But if they've had a significant infectious illness and have had vomiting and diarrhea, and then if they have any difficulty handling secretions or swallowing, important to look at the rest of the chemistry. LFTs as a transaminitis might suggest particular viral etiologies that are also associated with hepatitis. ESR and CRP to look for signs of inflammation, and then a CK given you're thinking about limb weakness and evaluating muscle enzymes. In all cases where you're thinking about AFM, I think it's important to send MOG antibodies. So just briefly touching on MOG. MOG stands for myelin oligodendrocyte glycoprotein. It's a protein on the surface of myelin, and the body can form an antibody to this, which is the most commonly positive antibody in pediatric autoimmune disease of the central nervous system. Can be associated with myelitis, and also with myelitis in combination with cranial nerve involvement. So can certainly be a mimic of AFM. While more often reflexes and tone are increased in this, particularly early on in the course, you can have diminished reflexes and tone as with transverse myelitis. And so in all cases of suspected AFM, I think it makes sense to send MOG antibodies. NMO or aquaporin 4 antibodies, which can be seen with neuromyelitis optica, and which is another cause of autoimmune myelitis. Enterovirus PCR from the blood. So in enterovirus A71 cases of AFM, blood is the most commonly positive specimen where enterovirus is found, versus in enterovirus D68, it's most commonly respiratory specimens, and then followed by stool, but much more commonly respiratory. Serum for CDC testing, which again, we'll hear more about later. And then other enterovirus serologies, Coxsackie A9, Coxsackie B, and echovirus antibodies are fairly readily available, and can be other important enteroviruses to evaluate for. West Nile serologies from the blood to the local state lab if you're in the US, and then other arboviral testing depending on the patient exposure and geographical area and the season. And the CDC has great websites that can guide you more in terms of arboviral testing. Other serum studies to consider that I typically will consider sort of as a stage 2 of my workup are EBV. I usually send the serologies first, and if those are positive, depending on the pattern of those, then I'll think about EBV PCR from the serum or the CSF, with the thought in mind that CSF is often quite valuable, and pre-IVIG serum is also valuable, and so the tiered testing sometimes helps. Same thing with CMV. VZV serologies in some cases, but those of course need to be interpreted in the context of many patients these days having been vaccinated, and older populations prior infection status. Lyme serologies in Lyme endemic areas, particularly if cranial nerve involvement is prominent, and nerve root involvement is prominent. Ganglioside antibodies if there's higher concern for GBS, for instance, if the MRI is normal early in the course. And ANA, now that can obviously be positive both in autoimmune diseases and in infections. And so, I sort of interpret that in the clinical context. But if it's very high, I might do more of an evaluation for systemic rheumatologic processes like sarcoid, and have that guide me, and then repeat that out from the acute illness. And then other testing, for instance, for sarcoid, ACE lysozyme, 25 and 125 hydroxyvitamin D. Other studies from other sites, so NP swabs and stool, enterovirus PCR and P swab, again, to reiterate, that's the most common site of isolation in enterovirus D68. The PCR from the stool is also sometimes positive in enterovirus D68, AFM. 2 stool samples for testing at the CDC, NP or OP swabs for testing at the CDC, an extended respiratory viral panel, which the particular viruses that are on that depends on where you send it, but typically we recommend that, and that usually includes flu, RSV, adenovirus, parainfluenza, human metapneumovirus, and oftentimes enterovirus/rhinovirus. And then with the recent case, important to bring up the possibility of polio testing, and asking about vaccination status to polio. May consider COVID-19 testing, and then other studies such as CMV, PCR in the urine or saliva. So we will hear more about this later, but reviewing the CDC's website regarding testing, sample requirements, and need for pre-approval for any testing that's going to be going to the CDC, and calling your local state lab for potential case reporting, as well as possible approval and guidance as you're doing this initial workup. If giving IVIG, just a plug that it's important to think about getting additional serum samples. Sometimes these kids are pretty small, and so you're limited in the amount of blood that you can draw on any given day. And the sooner you're drawing samples, the better in terms of infectious studies. But if you're going to be giving IVIG, your ability to interpret serologies after that IVIG has been given are potentially impacted, especially if you're thinking about common infections that are likely to have, be represented in IVIG. And then other recommendations and workup for readiness. So if you're working at a center, this is obviously not, aimed at general pediatricians, but if you're working at a center where you may see multiple cases, having an order set is a really helpful part of your toolkit. An order set allows folks, including folks who are not very familiar with AFM, to find recommended orders and place the correct order, including notes on sample requirements. And if you're creating an order set, you can also think about adding instructions for how to call your state lab and state health department to report a possible case, who to consult, for instance, in our institution, neuroimmunology, infectious disease, respiratory therapy, PT and or OT. And, that could be different in different locations. And then care needs can also be embedded in this, bladder scan, negative inspiratory force, isolation precautions, possible bed rest based on some data in polio, and then potential treatment. And these are just screenshots of the order set that we created at our institution that sort of walk people through. If you're seeing a patient in the ER and you're concerned for AFM, these are your steps. Those are my references. And then thank you so much, and I'll take any questions.
Great. That was a great overview, Molly. And I liked some of the practical points you highlighted, especially like getting additional serums, tubes for IVIG, since that can affect your results. We have a few questions in the Q&A. And so a question from Dr. Muraru is, could these labs be separated into tiers? I think she was talking during our blood work that you were mentioning. For example, we would not probably send CMV, EBV, or others at the beginning. Of course, it depends on presentation and context.
Absolutely, yeah. So the CMV, EBV, those are ones that I think about for sort of in a second tier, but you can also, see based on your basic study. So if you have a significant transaminitis, then it makes sense to send CMV, EBV, et cetera.
Yeah, and then does polio testing only has to be done in unvaccinated patients?
So I think at this point, primarily the CDC folks can answer this more, but I think primarily unvaccinated or under-vaccinated or immunocompromised individuals are where it's being considered at the moment.
Okay. And I actually think that they routinely test for polio whenever you refer for AFM. So that should hopefully cover it. One of the questions was stool samples sometimes take time to obtain. Would a PCR on a rectal swab also help?
That's a great question. For the most part, our lab has required stool and not rectal swabs because of, I think, detection and ability to detect in a rectal swab versus a stool sample. But we have had many cases where we're waiting on the stool for days and days, especially if they're quite constipated or have stool retention. Yeah.
Okay, great. And then there was a question about, can you share the order set from your facility?
And through most of the things that are on there through this talk, and so but I'm happy to if you want to email.
And then there's a question about serologies for Coxsackie. These would be usually detected using enterovirus primers, and I imagine that Coxsackie serologies would not be helpful since AFM occurs earlier in the course of the illness, and many children would have had exposure to Coxsackie in the past.
Yeah, we send it anyway. And it, if you have a positive IgM, then you're thinking, and if it's sky high, then you're thinking a little bit more. Okay. Obviously, if you have, a very high IgG, then it's taken a while for that to, to develop, and it's more suggestive of a past exposure or infection. Yeah.
Okay, great. There's a couple more questions. I apologize because I do want to make sure we get to all of our speakers today. So I'm going to go ahead and move on. So next, I'm delighted to introduce Dr. Becky Riggs, who is a pediatric neurointensivist who did her training in Oakland and also Children's National Medical Center, was the first pediatric neurocritical care fellow at Hopkins, was there on faculty for a while, and now is an associate professor in Portland, Oregon, and has led the pediatric neurocritical care subcommittee for the AFM working group. And so delighted to have Dr. Riggs talk about ICU and symptomatic management of AFM.
Thanks so much for that great introduction. I'm going to try to share my screen successfully. All right. Can you guys see my slides?